Okay, good morning all of participant of PDPI webinar. My name is Budhi Antariksa. I will be a moderator for today's webinar. Firstly, I like to express my gratitude to God that we are able to conduct this meeting online. And then welcome to Dr. Gur and Dr. Mulyadi as our speaker today. The first session is, there is a speech opening from Dr. Tria from PDPI. Dr. Tria?
Okay.
Okay, please.
Hello. Yeah. Thank you, Dr. Budhi Antariksa, for your invite for this session. I'm represent from the ISR in Indonesia Society of Respiratory or PDPI, Perhimpunan Dokter Paru Indonesia. We are glad here today that we have another webinar in this month regarding to the topic of asthma. We know that during pandemic this year, many problem and many disease correlated with COVID. One of them is asthma and COPD. And we want to develop and also update our knowledge about asthma particularly, not only COVID, but we want to upgrade our knowledge about asthma. And we very grateful today that our pharmacies that is PT GSK, Global Smith Klein, can support this webinar for this time with the title Optimal Asthma Treatment During Pandemic. And more interesting about this topic, this webinar this time, talking about telemedicine. Thank you for Dr. Mulyadi, Specialist Paru Consultant. Hello, Dr. Mulyadi, one of our scientific source for this session. And also, it's very interesting too to talk about ICS-LABA. You know that asthma, the backbone for asthma therapy is corticosteroids. So this webinar talking about ICS-LABA, whether fixed dose or flexible dosing, is really interesting. And we are lucky today that Dr. Gur Levy from Panama. Thank you, Dr. Gur, with your presence today. Maybe in your country now is at night, and here in Indonesia in the morning. So we hope that this webinar will give broad knowledge about asthma, not only COVID, and we can overcome this pandemic, whether this end until 2020 or whether still continue until 2021, but we hope this pandemic will finish soon. So we also thank you, Dr. Budhi Antariksa, today as moderator, Dr. Budhi, and we hope this meeting and webinar will be ongoing in very live discussion, and we can explore about asthma, not only telemedicine, but also the therapy for better asthma treatment. I think this is my speech for this, represent from Perhimpunan Dokter Paru Indonesia, and we hope Dokter Paru or pulmonologists in Indonesia will improve our skill and also our knowledge about asthma management. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Tria Damayanti. And as mentioned, Dr. Tria, that today webinar will consist of two topics. The first topic will be brought by Dr. Mulyadi, pulmonology specialist, with the title of Asthma Management with Telemedicine Utilization in Pandemic Situation. And then after that, the second topic from Dr. Gur Levy with the title of Fixed Dosing Inhaled Corticosteroid Long-Acting Beta Agonist versus Flexible Dosing Inhaled Corticosteroid Long-Acting Beta Agonist. Which one is more effective in managing asthma? After broad presentation, a question and answer session will be held. Participant can start asking the question by typing in the chat box during the or after the presentation. During the question and answer session, the question typed in the chat box will be read by the moderator or by the participant who asked. Without further ado, let's start our webinar today with the first topic, asthma management with telemedicine utilization in pandemic situation, that will be presented by Dr. Mulyadi, pulmonology specialist. Okay, I will read the curriculum vitae of Dr. Mulyadi. Dr. Mulyadi was born in Sawang, Aceh Selatan on August 9th, 1962. He graduated as a medical doctor from Faculty of Medicine, Airlangga University, and pulmonology specialist from Faculty of Medicine, Airlangga University, Surabaya. He later received his doctoral degree from Airlangga University. Now he works as pulmonologist at Zainal Abidin Hospital, Aceh. And he is also a staff of pulmonology division of Syah Kuala University Aceh. He is now practicing at the Islam Jemur Sari Hospital in Surabaya. I think Dr. Mulyadi, please.
Assalamualaikum warahmatullahi wabarakatuh. Terima kasih. Suara saya bisa didengar ya, Dr. Budi?
Bisa, Dok. Silakan.
Ya, pertama-tama saya menyampaikan welcome Dr. Gur Levy. We are early morning here. And my presentation in Bahasa, but my PowerPoint in English. I hope here. Yang pertama-tama ingin saya ada koreksi sedikit kepada Dr. Budi. Saya sekarang sebagai staf pengajar di Fakultas Kedokteran Universitas Nahdlatul Ulama di Surabaya, FK Unsa.
Oh iya.
Tidak di Banda Aceh. Terima kasih. Tapi sebelumnya yang pertama-tama ingin saya menyampaikan terima kasih kepada panitia yang telah memberikan kepada saya kesempatan untuk berbagi buah pikiran. Kalau saya mengatakan berbagi buah pikiran dalam suasana pandemi sebagai seorang dokter dalam melaksanakan praktisi sebagai dokter sehari-hari. Kita baru kemarin merayakan Hari Dokter Nasional. Dan kita tahu dalam musim pandemi ini banyak sejawat kita, guru kita, teman-teman kita yang gugur mendahului kita karena problem pandemi yang sedang kita hadapi sampai hari ini. Jadi doa kita untuk semua sejawat dan tenaga kesehatan, semoga diberi kekuatan dan ketabahan dalam menghadapi profesi sehari-hari. Menjadi menarik karena topik yang diminta kepada saya adalah buah pikiran tentang bagaimana manajemen asma terkait dengan penggunaan telemedicine dalam suasana pandemi. Telemedicine sendiri sebetulnya sesuatu metode yang sudah dipakai lama selama ini, cuman mungkin tidak seintens yang belakangan ini dalam hampir 6 atau 1 tahun terakhir ini. Seperti juga webinar yang sedang kita ikuti sekarang, itu setahun yang lalu tidak terbayangkan bahwa kita akan hampir setiap hari mengikuti webinar untuk menambah pengetahuan dan menambah wawasan, dan itu bisa kita lakukan dengan kehadiran fisik di mana saja. Jadi asma dalam konteks penggunaan telemedicine ini merupakan salah satu problem yang sebetulnya akan seharusnya menempati ruang yang banyak, menempati tempat yang luas, karena tujuan pada asma itu adalah bagaimana pasien-pasien itu bisa terkontrol dengan baik. Dan dalam suasana pandemi di mana dokter susah bertemu dengan pasiennya karena pasien takut ketemu dokternya dan dokter lebih takut lagi ketemu pasiennya. Itu real kita sehari-hari. Jadi jalan tengahnya dengan telemedicine. Dan topik yang hari ini kita diskusikan bagaimana buah pikiran tentang penanganan pelaksanaan asma pada masa-masa pandemi seperti saat ini. Berikutnya nanti Dr. Gur Levy akan menyampaikan beberapa penelitian yang terkait dengan penggunaan medikamentosa. Saya mungkin lebih masuk ke manajemen non-medikamentosa, yaitu telemedicine. Ada 3 pokok pembahasan yang akan kita pikirkan bersama. Ini mengulang kembali. Yang pertama adalah manajemen asma sebagai sesuatu problem yang long term. Dan bagaimana topik yang kedua adalah bagaimana kepatuhan daripada pemakaian kepatuhan daripada pasien itu sehingga untuk mencapai asma yang terkontrol. Dan di mana perannya telemedicine terkait dengan hal tersebut di atas. Kita sudah tahu semua, sudah diajarkan dalam kuliah bertahun-tahun tentang apa itu asma sebetulnya. Suatu kondisi kronik, suatu keadaan yang membutuhkan penata-laksanaan sepanjang masa. Dan semuanya itu tidak terlepas dari beberapa hal yang terkait dengan patofisiologi. Dalam filosofi saya lebih suka mengatakan kepada pasien yang datang bahwa asma itu bukan penyakit sebetulnya. Bahwa asma itu adalah suatu kondisi di mana tubuh kita tidak pada kondisi secara filosofi itu tidak seperti orang-orang yang dalam batas standar biasa karena hipersensitif. Jadi dengan patofisiologi yang seperti itu kita mencoba membuat pasien itu orang-orang bisa merasa tidak terancam oleh asmanya dan dia harus tetap hidup sebagai seorang yang sewaktu-waktu memiliki risiko eksaserbasi. Nah, ini saya mengulang lagi apa yang kita sudah tahu semua. Apa itu asma? Jadi sesuatu yang multifaktorial, heterogen, kemudian ditandai dengan adanya inflamasi yang bersifat kronik, yang ditandai dengan adanya keluhan sesak, napas yang pendek, dan batuk. Dan kita tahu patofisiologinya dimulai daripada hiperreaktiviti bronkus, hipersekresi mukus, dan bronkospasma. Dan semuanya itu akan menyebabkan airflow limitation. Jadi yang bervariasi antara satu dengan yang lainnya, antara satu orang dengan yang lainnya. Nah, pada hari-hari biasa, maksud saya hari-hari yang sebelum pandemi ini datang, kita senang dan dengan mudah melakukan konfirmasi daripada pasien-pasien yang kita temui di klinik. Jadi kalau mereka datang, kita lakukan pemeriksaan secara fisik, kemudian kita lakukan pemeriksaan penunjang, pemeriksaan fisik diagnostik, auskultasi, kemudian memeriksakan spirometri, kemudian memberikan pemeriksaan yang lain, seperti pemeriksaan laboratorium, dan apapun itu untuk melihat sejauh mana perkembangan daripada asma yang pada pasien yang sedang kita hadapi setiap saat di klinik. Nah, pada suasana pandemi, suasana ini menjadi suatu hal yang tidak memungkinkan untuk kita lakukan. Tetapi kita kepingin tahu bagaimana kondisi pasien kita, bagaimana kondisi sebetulnya klinis pasien kita. Sementara pasiennya tidak berani datang ke dokter, dokternya juga ketakutan kedatangan pasien. Sementara orangnya harus tetap mendapat pelayanan yang optimal. Nah, selama ini kita sudah diberikan jalan keluarnya dengan anamnesa. Walaupun secara praktis rasanya banyak di antara, bukan banyak, beberapa ada di antara kita yang mungkin tidak begitu merasa detail menanyakan kepada pasien. Dan mungkin pasien juga menjawab merasa itu bukan sesuatu yang esensial. Padahal pada kasus asma itu merupakan suatu hal yang sangat prinsip. Apa itu? Kita melakukan pertanyaan selalu kepada pasien dalam 4 minggu terakhir, 4 pekan terakhir ini, apakah ada keluhan enggak asmanya di pagi hari atau apakah ada terbangun di malam hari karena asma, ataukah memerlukan obat-obat reliever, atau pertanyaan lain, apakah ada keterbatasan daripada kegiatan sehari-hari. Jadi secara subjektif kita merasa pasien kita terkendali dengan baik apabila mereka menjawab tidak. Tapi kalau umpamanya 1 atau ada 2 pertanyaan itu kita ketahui semua bahwa ada yang tidak terkontrol dengan baik. Dan pasien-pasien seringkali tidak mengerti kenapa itu ditanyakan oleh dokter. Dalam konteks ini saya kembali lagi mengingatkan apa yang dulu pernah diajarkan kepada kita oleh para guru-guru kita, dan juga kita lakukan pada yang lebih muda, bahwa membuat pasien memahami patofisiologinya itu adalah esensi utama, sehingga pasien asma ini bisa memahami kenapa orangnya sesak dan kenapa poin-poin yang tadi kita tanyakan itu kita tanyakan selalu kepada pasien. Nah, ada parameter lain yang lebih objektif yang juga selama ini sudah kita kenal, yaitu asthma control test. Nah, saya menghimbau kepada kita semua, kepada kita bersama, setiap pasien asma yang datang seharusnya asma control test itu harus diisi dan terekam dengan baik. Nah, seringkali karena mungkin kita merasa, maaf ya, kadang-kadang pasiennya agak banyak atau waktu yang kita pakai terlalu sempit, sehingga hal-hal seperti ini terabaikan. Sehingga dengan demikian tentu kontrol daripada asma yang kita targetkan itu tidak kita punya gambaran yang utuh. Dan kembali kepada tadi pernyataan saya yang sebelumnya bahwa pemahaman tentang asma pada pasien tentang dirinya hidup sebagai orang yang memiliki risiko asma itu harus yang paling utama kita berikan pada pertemuan pertama bahwa kita mendiagnosa asma. Jadi kita tahu semua ini sudah tahu bahwa nilai maksimalnya 25 yang terkendali dengan dianggap well control apabila lebih daripada 20 nilainya yang berdasarkan asma control test itu. Nah, kalau kita menemukan pasien-pasien yang asma, ada beberapa hal yang membantu kita untuk memprediksi risiko-risiko untuk terjadinya eksaserbasi yang lebih tinggi. Dan ada beberapa hal yang perlu kita perhatikan. Yang pertama, apakah orang ini, pasien kita ini mendapat medikamentasi yang tidak adekuat, atau mungkin tidak mendapat kortikosteroid, atau pemakaian yang tidak betul, atau kepatuhan daripada yang tidak tepat daripada pasiennya dalam memakai obat-obat. Jadi, pemilihan obat-obat pada pasien asma, pada edukasi, itu perlu kita berikan sesuatu yang lebih detail. Biasanya pasien-pasien datang selalu seringkali menunjuk obat, minta sabar. Saya kalau pakai sabar langsung enak, Dok. Nah, kalau memakai ICS lama. Nah, itulah tugas kita untuk memberikan edukasi seperti yang sebelumnya kita diskusikan. Kemudian orang-orang yang memiliki risiko juga lebih tinggi untuk eksaserbasi, orang yang memiliki obesitas, memiliki GERD, memiliki keluhan chronic rhinosinusitis, atau yang memang faktor-faktor yang lain seperti alergi terhadap makanan yang berulang-ulang terus dikonsumsi. Nah, berikutnya kita lihat exposure daripada bahan-bahan yang lain, misalnya asap, rokok, kemudian polusi, kemudian kondisi-kondisi yang lain yang juga memiliki andil terhadap kemungkinan risiko eksaserbasi lebih tinggi, itu problem ekonomi, kemudian problem domestik, psikis di rumah atau di tempat kerja, kemudian fungsi paru yang juga tidak begitu bagus. Kalau kita periksa FEV1 kurang dari 60%, dan yang lainnya termasuk pemeriksaan hasil eosinofil maupun riwayat pernah dirawat di ruang intensif karena asma, atau paling dalam 12 bulan terakhir ini pernah dirawat di rumah sakit oleh karena eksaserbasi daripada asmanya. Ini beberapa hal yang perlu kita menjadikan prediksi terhadap pasien-pasien yang akan memiliki resiko eksaserbasi lebih tinggi. Ini semua kita sudah tahu, saya hanya mengulang kembali, mengingatkan kembali dalam kesempatan yang ini. Nah, ini target kita terhadap pasien-pasien asma, yaitu pasien yang terkontrol dengan baik. Nah, obat-obat obat reliever dan kontrol itu tetap diperlukan, tetapi pada waktu dan saat yang tepat. Jadi sabar kita berikan ketika muncul eksaserbasi untuk secepat mungkin melalui eksaserbasi itu. Tetapi kemudian kita lanjutkan dengan controller. Untuk apa? Untuk semuanya itu untuk mencegah berulangnya eksaserbasi, mencegah mengatasi bronchial hyperactivity, untuk mencegah airway remodeling dengan cara mencegah inflamasi daripada saluran nafas. Kita kenal pemberian controller yang selama ini kita berikan, ada beberapa ICS, kombinasi daripada ICS dan LABA, maupun oral corticosteroid. Obat-obat yang kontrol ini akan membantu memberikan efek bronkodilatasi dan antiinflamasi dan mengurangi eksaserbasi, dan selanjutnya akan memperbaiki daripada fungsi paru dan menghasilkan target daripada apa yang kita kerjakan, apa yang kita tujukan, yaitu asma yang terkontrol dengan baik seperti tadi dalam pembicaraan kita sebelumnya. Ini salah satu daripada publikasi yang menunjukkan bahwa pentingnya ICS dipakai secara teratur dalam rangka mencegah, mengurangi resiko eksaserbasi dan tentunya juga mengurangi resiko daripada mortality. Nah, bagaimana pada musim pandemi? Masa pandemi seperti saat ini, sampai kapan pandemi kita belum tahu. Nah, Gina merekomendasikan pemakaian kortikosteroid inhalasi maupun oral kortikosteroid masih tetap diperlukan, dan sebisa mungkin menghindari pemakaian nebulizer. Nebulizer dihindari dengan pemikiran akan memiliki resiko untuk memberikan media daripada penyebaran daripada COVID pada lingkungan-lingkungan di mana orang yang memakai nebulizer tersebut. Oleh karena itu pemakaian inhalasi salah satu yang direkomendasikan dengan baik. Dan kita lihat bukan cuma Gina, tetapi juga CDC, American College of Allergy, Asthma and Immunology, Asthma UK, PCCB, Asthma Council maupun European Respiratory Society mengatakan bahwa pemberian inhalasi kortikosteroid merupakan suatu pilihan yang utama pada kondisi-kondisi pasien-pasien asma yang kita rawat saat ini dibandingkan dengan nebulizer. Dibandingkan dengan nebulizer yang selama ini sebelum pandemi kita sering lakukan setiap waktu. Nah, di mana peran telemedicine dalam konteks penanganan asma untuk mencapai asma yang terkontrol tadi itu. Nah, apa itu telemedicine? Sebetulnya ya mungkin di sini saya tunjukkan beberapa pemikiran bahwa sebetulnya telemedicine ini sudah dilakukan lama, tapi terbatas selama ini karena beberapa hal. Yang pertama, belum terbiasa, belum terpaksa, dan belum terbiasa. Tetapi pada kondisi-kondisi tertentu dipakai untuk sebagai media untuk pelayanan kesehatan di mana jarak dan kecepatan pelayanan dibutuhkan secepat mungkin dan dilakukan oleh tenaga kesehatan yang profesional dan dengan memakai peralatan yang canggih, dengan peralatan yang mutakhir, dan tentu tidak semua tempat memiliki hal tersebut. Tapi dengan berkembangnya teknologi sekarang, dengan IT yang ada kita sekarang, seperti yang kita lakukan setiap hari termasuk webinar ini suatu keniscayaan telemedicine akan menjadi salah satu metode pelayanan kesehatan ke depan yang akan banyak dilakukan. Kita tidak pernah membayangkan di masa lalu akan ada telemedicine seperti ini, atau bagaimana kita bisa bercakap-cakap itu baru dalam 3 tahun terakhir. Nah, ke depan telemedicine ini akan menjadi salah satu pilihan yang utama dengan tujuan untuk meningkatkan pelayanan kesehatan baik pada individu maupun di masyarakat. Ada 4 elemen yang berperan yang terlibat dalam ini. Yang pertama, ini bertujuan untuk pelayanan kesehatan. Yang kedua, telemedicine ini dilakukan untuk mengatasi barrier, mengatasi batas geografik yang ada, keterbatasan jarak dan tempat, dan melibatkan alat IT dengan tujuan utamanya itu adalah untuk memperbaiki pelayanan kesehatan. Nah, bagaimana kita melakukan itu? Ada beberapa tahap. Tahap pertama yaitu persiapan, dan biasanya dalam beberapa tempat pelayanan kesehatan sekarang di beberapa tempat sudah ada, di beberapa rumah sakit sudah ada, beberapa unit kesehatan sudah ada. Yang pertama, mempersiapkan tempat, yaitu ruangan, kemudian semua yang terkait dengan itu disiapkan, termasuk IT-nya, termasuk penjadwalannya, termasuk apa yang akan kita diskusikan kepada pasien. Tentu semuanya ini kita juga tidak bisa menafikan harus ada harus kita memenuhi privasi yang mengikuti kepada sumpah jabatan dokter melindungi pasien, termasuk menjaga kerahasiaan daripada pasien yang berkonsultasi. Kemudian selama konsultasi kita mengupayakan bagaimana harus ada kesepahaman dulu apa yang akan dibicarakan, dan kemudian pasien itu harus juga jujur. Seperti biasa kita bertemu, kadang-kadang pasien kan tidak jujur. Nah, pada kondisi-kondisi seperti ini kita harus minta kesepahaman yang tadi saya sampaikan. Dan kenapa informasi ini dibutuhkan? Dan pasien juga memberikan kepada kita bagaimana feedback yang dia peroleh selama konsultasi kepada kita. Dan setelah konsultasi, tetap harus ada medical record. dalam konteks ini saya ingin mengatakan bahwa demi untuk menjaga kerahasiaan pasien, dari awal harus kita sepakati bersama bahwa apa yang disampaikan dalam diskusi ini hanya untuk konsumsi dokter dan pasiennya. Kira-kira seperti yang kita hadapi sehari-hari. Ini yang tadi saya sampaikan, melengkapi dokumentasi, kemudian kalau perlu dengan email, kemudian maaf ini saya percepat saja, waktunya sudah habis, mau hampir habis. Bagaimana telemedicine untuk asma? Apa tujuannya? Di sesi awal tadi, di poin pertama tadi, tujuan daripada asma adalah untuk memperbaiki, untuk meningkatkan pelayanan kesehatan. Yang kedua, target daripada asma itu untuk asma yang terkontrol. Asma yang terkontrol itu hanya diperoleh apabila pasien-pasien itu memiliki kepatuhan dan pemahaman yang maksimal. Nah, telemedicine ini membantu kedua hal ini. Membantu pelayanan, meningkatkan pelayanan dan membantu kepatuhan daripada pasien terhadap apa yang seharusnya dilakukan dalam kapasitas sebagai seorang yang memiliki riwayat asma. Ini adalah ada penelitian dari WNW tentang pemakaian telemedicine. Jadi kita lihat dalam diagram ini yang terbanyak diabetes dan asma baru 9%. Dan ke depan saya merasa setelah telekonferensi ini, webinar ini, mestinya telemedicine asma akan meningkat lebih banyak di negara kita. Nah, ada beberapa keuntungan dan beberapa tantangan dalam menghadapi telemedicine terhadap asma. Ini penelitian yang dipublikasi. Ya, keuntungannya terhadap individu, kemudian pelayanan kesehatan, kemudian masyarakat seperti yang bisa dilihat pada tabel di sebelah kiri. Dan tantangan kepada kita yaitu termasuk teknologi, termasuk kemudian skill, kemudian bagaimana hal-hal yang lain terkait dengan telemedicine dapat kita lihat pada sebelah kanan. Nah, ada juga penelitian yang lain tentang masih hal yang sama, mendapatkan ternyata telemedicine terkait dengan asma akan memberikan efek hasil yang optimal, lebih optimal dalam meningkatkan kualitas maupun target daripada tujuan daripada penelaksanaan asma sebagaimana yang saya sampaikan di depan. Ada penelitian yang lain lagi, ini beberapa variabel yang dipakai, tujuannya yaitu dengan pendidikan, dengan apa namanya, memakai video conference, kemudian early detection, deteksi awal dengan screening fungsi paru secara jarak jauh, dan tentu dilakukan dengan persiapan yang lebih telah dipersiapkan, termasuk di sini untuk meningkatkan kepatuhan daripada pasien terhadap asma, terhadap penata asma, kepatuhan daripada penata asma sebagaimana yang telah kita diskusikan di awal. Nah, siapa yang kita lakukan telemedicine? Tentu tidak semua. Pada kondisi-kondisi yang memerlukan perawatan di rumah sakit tentu tidak bisa dengan telemedicine. Nah, asma pada kondisi-kondisi yang lebih ringan merupakan target yang paling ideal sebetulnya untuk mencegah supaya tidak jatuh kepada tidak terkontrol. Jadi bisa secara video call, bisa secara tadi saya sampaikan dengan institusi pelayanan kesehatan, dengan melalui apa yang kita harapkan dari pasien, riwayat yang detail, kemudian pemeriksaan fisik yang terbatas, yang sederhana, full oximetry bisa kita lakukan, kecuali pemeriksaan fisik auskultasi tentu tidak mungkin dilakukan dengan telemedicine. Nah, pada kondisi tertentu mungkin bisa kita lakukan fibrometer kalau memang alatnya tersedia di tempat yang tersebut, di tempat yang kita lakukan telemedicine tersebut. Ini beberapa hal, ini inovasi-inovasi yang bisa kita lakukan dengan cara kita masing-masing sesuai tempat masing-masing. Jadi telemedicine pada pasien asma ini akan membantu mencegah penderita asma untuk eksaserbasi, kemudian dengan tentunya mendapatkan apa yang kita dapat targetkan, yaitu asma yang terkontrol dengan baik. Dengan demikian akan meningkatkan kualitas hidup dan meningkatkan kualitas daripada fungsi paru, dan relatif telemedicine ini tidak memberikan resiko yang tinggi sejauh itu dilakukan dengan protokol yang tepat, dengan cara-cara yang tepat, dengan pada pasien-pasien yang memang untuk dilakukan untuk porsinya telemedicine. Tentu pada pasien-pasien tadi sudah kita sampaikan di awal yang terpilih. Nah, apa pesan daripada ingin saya sampaikan pada kesempatan ini? Kita ketahui bersama bahwa asma merupakan suatu kondisi inflamasi kronik yang membutuhkan penata-laksanaan sepanjang hidup, dan untuk antiinflamasinya itu pemilihan kortikosteroid merupakan yang utama dan perlu dilakukan follow up lebih lanjut. Yang berikutnya, asma yang tidak terkontrol, saya rasa termasuk di Indonesia, di kita, merupakan problem utama karena pemahaman daripada masyarakat terhadap asma belum sepenuhnya sebagaimana yang seharusnya, dan kepatuhan terhadap apa yang disampaikan tidak sebagaimana juga seharusnya. Dan telemedicine akan membantu ini semua, kepatuhan, dan sehingga menyebabkan kontrolnya asma kontrol akan dapat tercapai dengan optimal. Dan telemedicine merupakan suatu ide, suatu konsep yang akan menjadi salah satu pilihan utama pada pelayanan kesehatan di masa depan, khususnya pada pasien-pasien pada kondisi-kondisi yang kronik, termasuk dalam konteks ini asma. Dan saya merasa bahwa telemedicine ini sudah waktunya masuk ke dalam kurikulum pendidikan kedokteran, yang mungkin selama ini dianggap sambil lewat, tetapi ke depan dengan pandemi ini, dengan pelajaran dari pandemi ini, salah satunya akan meningkatkan telemedicine sebagai salah satu bahagian daripada pendidikan kedokteran di mana saja. Saya rasa 3 hal itu yang ingin saya bagikan buah pikiran, mudah-mudahan bermanfaat tentang pemikiran tentang telemedicine. Dan sebelum saya tutup, saya ingin mengingatkan suatu apa yang dikatakan oleh kata-kata bijak Oliver Wendell Holmes, bahwa salah satu tugas daripada dokter adalah melakukan edukasi kepada masyarakat. Dan telemedicine salah satu media yang paling ideal untuk hal tersebut, dan generasi yang akan datang, sekarang masih menjadi mahasiswa, akan melanjutkan metode ini dengan dalam inovasi yang akan lebih baik. Demikian dari saya. Terima kasih kepada moderator. Saya kembalikan.
Baik, terima kasih Dr. Mulyadi atas presentasi yang menarik tentang telemedicine dan pengontrolan dari asma. Okay, let's move on the next topic. The title is Fixed Dosing Inhaled Corticosteroid with Long-Acting Beta Agonist versus Flexible Dosing Inhaled Corticosteroid Long-Acting Beta Agonist. Which one is more effective in managing asthma? That will be presented by Dr. Gur. And then I will read the curriculum of Dr. Gur. Dr. Gur is pulmonologist with more than 20 years experience. He graduated as a medical doctor from Faculty of Medicine, Carabobo University, Venezuela, and pulmonology specialist from University of Venezuela. He later received his magister degree of organ transplant from Barcelona University. And I think you are the fans of the Barca. Okay, and then his work experience include pulmonology professor at Stroll Medicine in Pulmonology, Venezuela, secretary of Latin American Association of Thorax, and a regional medical engagement head of emerging markets in GlaxoSmithKline. So please, Dr. Gur Levy.
So thank you. Good morning, good afternoon in Indonesia. For me, it's right now evening Saturday. It's 10:47 p.m. in Panama. But I'm not from Panama, I'm from Venezuela. I'm living right now in Panama. So thank you so much, Dr. Budhi. Thank you so much, Dr. Mulyadi and Dr. Trilla also. Here is my disclosure. It's my first time that I'm working for a pharmaceutical, for industry. It's my first time. So I'm working for GSK. I'm right now a full-time employee of GSK. Next slide, please. During my presentation, I will go through the asthma control to review the asthma control as the state of the art. I will go through the asthma treatable traits, through the Gina therapeutic strategy. I will go through a case clinic to discuss with you. And for that, I will hold with you at least 3 or 4 questions that you can answer them through the pigeonhole. So please, I will need your support from all of you in Indonesia to answer to those questions to make this case clinic more interactive. Obviously, I will go through my case clinics looking for if we should be using a proactive or a reactive strategy, and the conclusion of this of my presentation. If we can go to the next slide, please. Okay. In asthma, not everything should be medicine or drugs. We, as a doctor, when we are in front of a patient, we should try to understand that patient, to understand how he's taking his inhalers regarding the adherence, if he know or he don't know how to use the device, because as we know, more than 50–60% of our patients, they don't know how to use the devices. We should ask to the patients for their preference using devices, and obviously also with non-pharmacological strategies. We should treat not only symptoms, not only to reduce this short-acting beta-agonist overuse. We should try to improve the activities that those patients has. We should try to improve the quality of life, and also, if it's possible, to improve the lung function. All those, let's say, key points will be, you know, we have risk factors that could make from those symptoms that they could be worse. Some of them could be the exacerbations. Obviously, some patients could be hospitalized regarding the asthma. They could die regarding the asthma. I was reviewing the mortality in Indonesia. We should be reviewing the lung decline of those kind of patients, and we should understand that those patients, as this is a chronic inflammatory disease, if we don't treat the inflammation, those patients will have more hyperactivity and more remodeling of the airways, and with that, more lung decline, more exacerbation, more hospitalization, and more risk of mortality. So we have a disease that is a chronic disease and could have some, let's say, key issue that could make them a disease that could be a disease activity. We have, as our doctor mentioned before, the comorbidities in asthma are very, very important. Not only sinusitis, also chronic rhinosinusitis, allergic rhinitis, and obesity, as it was mentioned before. And obviously, we should try to understand that in our countries, most of our patients that are asthma patients, they're still smoking. And we know that if those patients are still smoking, they will be with more risk to be uncontrolled in that way. If we can go to the next slide. And this will be my first question for the audience. So my first question for the audience will be, I bring to you this concept of treatable traits in asthma. And my question here is, treatable traits in asthma can be defined by overlapping disorders, option A, comorbidities, option B, environmental, option C, behavior, option C, option E could be A and B are correct, or option F, all above. I will give you 10 seconds to see your answer right now. So let me check. You have 10 seconds. Please.
Ya. Bapak Ibu dapat bisa memasukkan pollingnya di pigeonhole.at dan memasukkan passcode-nya PDPI, lalu di pilihannya ada untuk polling, silakan dipilih untuk pertanyaan pertama jawabannya.
Thank you so much for the explanation to take over the pigeonhole. So I will give you 30 more seconds to have everything on board. It will be very easy. And let's do it more interactive in that way. Okay, let's check. Wow, great. 73%, it's okay. 75% of the audience, and we are near, I don't know how many we are in the audience, but 75% of our attendees, they say that are all above. And you are correct, are all above. Okay, if we can go to the next slide, please. Obviously, the A and B are also correct, but also the C and D, and I will show you why, and it's really important. Look at this. Regarding when we have in front a patient with asthma, we're trying to reviewing his treatable traits, we should be thinking an overlapping disease as cough, reflex bronchiectasis, vocal cord dysfunction, or COPD. Also regarding comorbidities, as we mentioned before, obesity, side effects of the treatment, really important is the depression, rhinosinusitis, and obviously the gastric results. For those that you didn't think that it could be also the environment or the behavior, yes, and both are very important. Let's go through the environment. Our cigarette smoke, indoor and outdoor air pollution, workplace exposure, and exposure to sensitive agents. So in that way, not everything should be to treat with drugs, with medicines, or to treat comorbidities. Also the environment of this patient. And regarding the behavior, we know that there is no relation between the symptoms, the perception of the symptoms, and the control. If we review all the studies that were done 10, 12 years ago, asthma anxiety reality for Europe, for Asia Pacific, for US, all of them show to us that there is a big difference between the perception of the patient. They perceive that they are controlled, but they are not controlled. Also, regarding the inhaler device, the polypharmacy, maybe we're talking about adults, patients over 40, 50, 60 years old, that they could have more comorbidities. Obviously, they could be receiving more and more medicines for the other disease. So it could be an issue for those kind of patients, and we should try to understand how to treat those kind of patients. And obviously, regarding the family and social support and poor inhaler technique, that it becomes an issue. And I will go back to the previous presentation that I really like it regarding the telemedicine, because I've also used the telemedicine to review how the patient is using his device. Because we know that when our patients, they come to our office and we ask them that we want to see how they're using the device, they can tell us, oh, doctor, I leave my device, my inhaler in my house. So it's really difficult to see how they're using their device. I also tell them, you should bring your device to my office or to the hospital. But right now, if we're going to get them telemedicine, I will tell them, and obviously, if it will be in a video call, please show me right now your device, and I want to see how you are using your device. So in that way, with telemedicine, we can also improve the inhaler technique of those kind of patients. We can go to the next slide, and that was a great presentation from our doctor. Right now, I'm going to the Gina Strategy. Most of you know about the Gina Strategy. Gina Strategy has changed in the last 2 years. Let's say again in this last year, we have the same, let's say 5 steps. Okay. Remember that Gina is not a guideline. Gina is a strategy. Okay, in that way. They introduced something new regarding the step 1. So they introduced the possibility to use ICS formoterol. And why? Because formoterol is a drug, is a LABA that has its fast action. So in that way, they introduced the ICS formoterol as needed for those patients that they are, let's say, intermittent. And obviously, you can still using short-acting beta agonists, but they prefer that if the patient should be using the short-acting beta agonist, it should be used always with the ICS. That's new in the step 1, because previously was only the short-acting beta agonist as that. Here, and those kind of, let's say the step 1, step 2, let me go to the step 2. In the step 2, we have 2 possibilities to still using ICS as the preference choice to control patients in the step 2, or to use ICS for motor as needed. As the first option. Step 3 and 4, obviously, to step up regarding the ICS LABA, and in 2 different strategies, fixed dose or in a MAR therapy of ICS LABA in terms of a different approach of flexible dose. And the step 5 that will be ICS LABA plus a third controller in that way. Let's see the step 1. And here is an issue. How many patients that we have today, they have less symptoms, less than twice in a month? Not so many. Let's see the step 2. Symptoms twice a month or more, but less than daily. If we review all the studies that were done with PRN, ICS for motor in PRN was the study Sigma 1, Sigma 2, the practical study. If we can go to the next slide, and in that way, the START study. I have here a summary of those studies, and let's check. Let's check the step 2. Regular ICS improve asthma control better than ICS LABA using in PRN. Because if you review those studies that were published in New England Journal of Medicine, they tell us, and it's part of the conclusion, that in terms of exacerbation, ICS plus short-acting beta agonists, it's equal that ICS for motor. In terms of reducing exacerbation, and better than to be using short-acting beta agonists, obviously. So, in that way, ICS plus short-acting beta agonists, there is no difference with ICS for motor regarding reducing the exacerbations. The big difference is regarding the control. Because in both studies, they show to us that the best controller is when the patient is receiving ICS in fixed dose plus short-acting beta agonists. So, in that way, my conclusion should be, if what you are looking or we are looking for a patient, it's only to treat symptoms to reduce the exacerbation, you can use you can use ICS plus short-acting beta agonists or ICS for motor as needed. But if you want to reduce the risk of exacerbation and also to achieve asthma control, the best option is ICS in regular fixed dose plus short-acting beta agonists. And that are in both studies, they are part of the conclusion of both studies. But not all those speakers that talk about that study, they're only talking about the reduce of exacerbation. And I think, and you also will, I think that you will agree with me that we cannot only reduce the risk of exacerbation, we also need to try to achieve asthma control. And in the studies, the practical study, and the START study that were done with ICS for motor against ICS budesonide and against terbutaline, also the inflammation was higher in the PRN. So that's the reason that the patient cannot achieve well asthma control as we can achieve it with the ICS. And in terms, and I love the last slide of the previous presentation because it mentioned regarding the education of our patient. We cannot try to treat patients regarding symptom driving because it will be easier in that terms. Because if we are going to treat patients regarding the symptom driving in that way, what we will be doing for those patients is that they will maintain the inflammation and more hyperactivity. And in that way, they could have more remodulation of the airway. And we're doctors. And we have to treat and to try to achieve asthma control for our patient. Let's go to the next slide, please. So let's see our case. I will say that this is not the name of my patient, okay? She has another name, okay? But I love this name when I was reviewing the names in Indonesia. That's the reason that I include this name as part of my presentation. But obviously, it's a case clinic from that was referred to me. So she has troubles of asthma with daytime symptoms. She has 2 courses of oral corticosteroids in the past year regarding exacerbation. She has 54 years old female with 1 teenage children. She works as a sales representative in the cosmetic department. She's a non-smoker and she's an asthmatic patient since she has 15 years old. So she is a female, and as we know, most in adult patients, the prevalence of females are higher than in males. You can see here the lung function. I don't show you both of them, but I can tell you that the FEV1 was 2,200 milliliters. She improved at least more than 12% and 200 milliliters after the short-acting beta agonist. So she has a lung function that is reversible in that way. So this patient is an asthmatic patient that was referred to me. Let me show you after the second way. Let's go to the next slide, please. And here is the question for the audience. Again, let's see. How would you assess nurse asthma level of control? With the asthma control is based by my own criteria because I am not using you in your office. You don't use any kind of tool. You use your own criteria, or you use a peak expiratory flow, or you use the consensus-based Gina symptom control, or you use the asthma control test, or you use the asthma control questionnaire. As you know how to do it, I will give you 20 seconds to try to answer to this question. So let's see. You have the option A by your own criteria. Option B will be the peak expiratory flow. The option C, this is not the answer. Okay. Great. Wow. Let's stop here. Great. I have to be in Indonesia face to face. Let's be honest. I want to be there. So let's see if this pandemic will improve. You can use the asthma control test, as maybe 45% of you mentioned it. You can use also this one, that is the Gina assessment of asthma control, okay? But this one was done as a consensus by the Gina members. This has not evidence in that way. And that is really important. But obviously, the 4 questions are really good. Sorry, before I'm going through this one. You can use also the asthma control questionnaire. Asthma control questionnaire is also a tool that that I also use it for other kind of patients. Let's say, no, please don't go through the. Okay, let's maintain this slide. We can, regarding the peak expiratory flow. The peak expiratory flow, it's not a tool to achieve asthma control. It's a very good strategy, the peak expiratory flow, to see how the patient is regarding his peak expiratory flow, to see how is the variance during the day. I use it if I'm thinking that the patient has any kind of asthma regarding in his workplace. I use it a lot, or regarding as part of the education. Here is the asthma control test. The asthma control test, as it was mentioned before, you should ask, as this is a chronic inflammatory disease, we will be always asking for the last 4 weeks, because sometimes the patient, when he's in our office, he's thinking what happened to him or to her yesterday or today. And we need to understand that as this is an inflammatory disease, we should try to understand what happened in the last 4 weeks. The gene assessment, they use the same 4 first questions, but in a dichotomic, you should only answer in a dichotomic pleasure. So yes or no, yes or no. I don't like it. I have to be honest, I don't like it. I love the asthma control test, also the asthma control questionnaire, but I love this because it's easier. This patient nurse, when I asked her regarding how often she's asthma prevented you to getting as much done at work, but she was working, she told me a little of time, so 4 points. During the past 4 weeks, how often have you had shortness of breath? She told me only 3 times in a week that she wake up regarding their asthma, only once in a week. So it seems only once in a week she wake up, only 3 times in a week she has shortness of breath. She told us that only a little of time she has any kind of issue regarding his work, that she only used twice the inhaler, the short-acting beta-agonist, that could be any kind of short-acting beta-agonist in the last week. So it seems that she is on control. And as you can see, the last question is really important, because for me, the last question, with this question, I can educate my patient, because when I ask her, how would you rate your asthma control during the last 4 weeks or the past 4 weeks? She told me somewhat control. I will tell you, or I will tell her, I told her, no, you was not somewhat control, and I will explain you why you was not somewhat control. Because you need to have more than 19 points, so from 20 to 25 to be controlled and well controlled. So in that way, we should try to improve in the way to have more than 20 points. So in that, for the first question, it's not any kind of issue to have only 1 or 2 times short of breath, or not at all, or to wake up regarding their asthma not at all in the last week, or not to use the short-acting beta-agonist. So in that way, we can educate the patient. We can go to the next slide. So she has, I cannot see the slide, but it was 4, 3, 4, 12, 4, 16 points. So if she has 16 points, she is on control. And it's really important, as it was mentioned in the previous presentation. asthma control test and the exacerbation risk. The asthma control test, it's able to predict the exacerbation risk. So you can see that if the patient has less than 19 points, less 15 points, as this patient has 16 points, the risk of exacerbation is higher than if this patient has a asthma control test more than 20 points. So that's the reason that I love to use the asthma control test in all my patients. I will say in all my patients that are in the stage, from the stage 1 to the stage 4, step 4, okay? Because I also use the step, I obviously, for the step 5, I can also use the asthma control test, but with the lung function. If we can go to the next slide, please. And it's really important because when I was reviewing, you know, they told me that I will give this presentation for Indonesia. I was looking for the Indonesian data. And my pleasure here was that this paper was published this year in the International Journal of Human and Health Science by the University of Indonesia, by the Department of Internal Medicine, the Pulmonology and Allergy Department. And regarding, for me, it was a pleasure because it was regarding the asthma control test as a predictor of asthma exacerbation among Indonesian Hajj pilgrims in 2018. I will not go through it with all the details, but they have 8,500 pilgrims, and from them there were 72 had asthmatic patients, but only 68 were included in the study. 67% of them were female. Lower than 60 years were 66%. If we can go to the next slide, they used the spirometry, they used the asthma control test, they used also the saturation in those kind of patients. And as we can see here, from the first ACT at Puskesman and the ACT at embarkation, we can see that at least 53% of the patients, they were partial control. And near 19% of the patients, they were on control. And the risk of exacerbation of those patients was higher because for the partial control patients, they have a risk of exacerbation of 48%. And for those patients that they were on control, the risk of exacerbation was of 62%. So the asthma control test will tell us it's a predictor of exacerbation. So what means, let's go again, that if we try to achieve asthma control, those patients will be using less short-acting beta agonists, and they will have less risk of exacerbation, and they will, but for that, they should be controlled. Let's go to the next slide, please. So we have for Nur that she is an uncontrolled asthmatic patient. She's in the step 3 to 4 in that way. We should be using ICS-LABA, but we have two possibilities, two approaches, is to use a fixed dose as it was done in the Gaining Optimal Asthma Control, in a step up to achieve control, or a step down if we need it, if the patient is still well controlled, or to use a strategy as the MART strategy that it's using ICS formoterol regularly and as a reliever in that way. So patient can take extra dose when needed. Let's go to the next slide, please. And here my third question for the audience. Regarding the use of this kind of approach of ICS-LABA, in what proportion of asthma patient is asthma control achieved with ICS LABA given in a marked approach. So also ICS for motor also as needed for the step 3 and 4. So, and let's go no so fast. Option A, please not stop. More than 70%, 75%. Option B, about 75, about 50%. Option C, option B, 4, 25% and fewer than 25%. Option 5 or E in that way. So I will give you 10 seconds. If we can, you can go to the next to see the answer. It's working very well, the pigeonhole today. This is not the okay, right now, yes. Please stop here. I don't want you to move the slide, okay? This answer only 2.8%. So only 3% of the audience know this answer. Only 2.8%, because also was lower than 25%. The point here is, I know what happened to you. I understand. Don't worry about that. Sometimes we think that with this kind of approach, patient can be controlled. Let's go to the next slide. And I will show you through our case clinic what happened. Let me show you this slide. You can see in the right side, the gaining optimal asthma control approach is the fixed dose with fluticasone propionate plus salmeterol. In the left side, you can see the marked strategy with more than 12,000 patients in those 5 studies that you can see done by Rabe, published in Lancet, by Paul O'Byrne, published in the Blue Journal, by Suchitiano in the Curative Medicine Respiratory, by Cunha in the Journal Clinical Practitioner, and Busquet in Respiratory Medicine. If we review, and that was done by Bateman, you can see that with the marked strategy, only 70% of the patient can achieve asthma control. Most of the patient, they will be partial, 38% of the patient, and 44% of the patient will be uncontrolled. And let's see on the other side, with the gaining optimal asthma control, that anyone can achieve this kind of results. You can see that between control and totally control, we achieve 74% of the patients. So with this strategy, from the gaining optimal asthma control with fluticasone propionate plus salmeterol, those patients can achieve between 71 to 72, 74% of the patients. With the marked strategy, only 17%. And those studies were done by those authors. And this was published. Let's go to the next slide. And that was the reason that also when they was talking about the strategy in the step 2, obviously there is a lot of noise regarding to use PRN. Obviously, you can use PRN, but it's as the same as the MARC therapy in the step 3 and 4. With the PRN, you can reduce exacerbation, but less patients will achieve asthma control. And in the step 3 and 4, only 70% will achieve asthma control. If you will have a strategy regarding symptom driving. Let's see what happened to NER. The doctor, he believed, because he was hearing a lot about MARC therapy, MARC therapy, MARC therapy. They don't tell him, they told him, to the doctor, that is a really easy device, that you can use the same device as a controller and as a rescue drug, that it's a ICS LABA. Budesonide and formoterol are good drugs. I will not say nothing about that. They are good drugs. In terms to relieve the symptoms, they're good as a short-acting beta agonist. Obviously, as it has budesonide, it has a controller in that way, so it's better. But, so this patient, when she received budesonide formoterol in MARC therapy, she has no future exacerbation or nighttime weakness, but she was using also as needed 5 in a week. Now feels that she has improved and she has the maintenance component, and she was using the drug 8 weeks. She came to my office. It was impossible. In the pharmacy, they don't have the step-up therapy. I told her to use the serotype Acuheller in a higher dose, but it was impossible for her. So she has the 100 micrograms, 25 twice daily in that way, plus salbutamol as rescue medication. He continues not to have exacerbation, but still have some kind of using reliever. Let's go to the next slide. And here is the state of the art of this kind of patient. Why? Because his current treatment issue was that she improved, but she still has excessive symptoms. So she was not controlled. She was using a lot of short-acting beta. So in the approach that she was using ICS LABA, the option was to step up the therapy in that way, and stepping up the therapy and maintaining in the stepping up as the gaining optimal asthma control, we can achieve the asthma control. This patient was only using reliever, short-acting beta agonist, only once in a month, and after, in the first 4 weeks, she has a asthma control test of 21, in the second month of 22, and in the 4th month of 24. We can go to the next slide, please. This is how is the approach. Why? If we have a patient in front and we know that he still has symptoms, we should review if asthma control was well diagnosed. This is the case. The adherence of the patient, because sometimes if the patient don't have adherence to the treatment, they obviously will still have symptoms, exacerbation, or they will be uncontrolled. If we know that the patient is receiving a drug, it's using well the inhaler, the device. We know that we're reviewing the device, how they're using the device, and he or she still has symptoms, we should be reviewing the comorbidities of she's smoking or whatever regarding the tuber traits. If not, we should step up. We cannot leave the patient to be using as needed medication, because if not, she will leave the medication in that way, and she will have more inflammation, more hyperactivity, and more remodeling. And in this strategy, if we achieve asthma control for at least 8 to 12 weeks, we can maintain the patient in that treatment, or we can reduce the treatment if it's needed to the step down, one step down. We can go to the next slide, please. So here you can see what I mentioned to you before, the 3 different steps, how with the approach of fluticasone propionate plus salmeterol in the gaining optimal asthma control, patient can achieve a well control or totally control, at least for those patients that were naive of ICS, near 78% of the patient, but those patients that were receiving beclometasone before, in equivalent of 500 micrograms by day, 75%, and in those patients that they were receiving beclometasone higher than 500 micrograms, they could achieve at least 62% of the patient. With the MARC therapy, in 5 studies, they only achieved 170% of the patient control. If we can go to the next slide, here it's really important. This slide, with this slide, what I want to show you is not, let's not see the 71%, okay? The most important here, and I cannot have the laser to show you how it was, but you can see that if the patient will still receiving the treatment, more patients will be achieving asthma control. That's the reason that we should maintain the treatment over the time. So more patients will be achieving asthma control. If the patient will be, using as needed and not use, and again, with symptom driven, they will not achieve asthma control. They will reduce the symptoms. Yes, they will reduce the risk of exacerbation. But they will not achieve asthma control, and they will have more hyperactivity, more inflammation, and more risk of remodulation. Let's go to the next slide, please. If the patient is well controlled, as you can see here in the 3 different stratum, if the patient is totally controlled or well controlled, the risk to have instability of their asthma is very, very low. That's the reason that we should talk to the patients and let them know that as this is a chronic disease, an inflammatory disease, they should be receiving the drug over the time. And here it's really important also in telemedicine right now with this pandemic of COVID, because what we try to do is that if those patients that are well controlled, they have less risk of exacerbation and less risk to go to the hospital. And maybe because in the hospital, we should try to maintain those hospitalization for patients with COVID or patients that they have really reason to be hospitalized, not be regarding that this patient is not using the controller medication that they should be using for that. Next slide, please. I think that there would be here, it's only a summary between both strategy, and you can see here as with the gaining optimal asthma control, you will have better in terms of symptom, less symptom-free days, higher 72% in the gaining optimal asthma control. Only with MARC therapy with ICS formoterol, they will have only the percentage of symptom-free days 44, so lower than for fluticasone propionate plus salmeterol. The need of rescue medication is higher with this MARC therapy with ICS formoterol. They will have less free days of using the rescue medication. You can see that with the gaining optimal asthma control or fixed dose with fluticasone propionate plus salmeterol, the patient will need less rescue medication and will be free days with rescue medication, better peak expiratory flow, and in that way, less exacerbation. I will go to my last slide and to give opportunity to the Q&A session. Let's go to the next slide, please, if we can go. I cannot see. Okay, here, and here is the reason. And let's show you the reason of why the MAT regimen increased bronchial inflammation versus regular ICS-LABA. This study was published, and you can see that in a MAT regimen, patient will maintain, in sputum, induced sputum or endobronchial biopsy, more eosinophils in that way than in regular use. That's the reason that also for the step 2, patients should be receiving fixed dose. Next slide, please. And this, I think that this will be this is the certified safety information. Remember that only that patients should be, using, to wash their mouth when they're using any kind of ICS, Let's go to my summary slide, please. It's really important to achieve asthma control. Continue treatment, improve asthma control. There is no evidence that better asthma treatment outcome can be obtained by symptom driving. And as I show you, with seretide that way, or with fluticasone propionate plus salmeterol, you can achieve 71% of well asthma control. But more important than that, and I mentioned that in my first 2 slides, it's not, when we're having front the patient, it's not only related to medicine or drugs that they will be receiving, it's also how we manage the comorbidities, the environment, the inhaler device, and to be proactive. In our daily activities, we should be proactive. And in asthma patient, we should be more proactive treatment and not to try to achieve asthma control and not to be reactive to the symptoms. Because we know what happened 30 years ago, 25 years ago, before the ICS-LABA came to our lives and give us the possibility to achieve asthma control as we're doing today. Thank you so much.
Okay, thank you, Dr. Gur, for your nice presentation. We move to the question and answer or discussion. This is there is 2 questions from the audience. First, from Dr. Made Agustia Dharma Putra to Dr. Gur Levy. I am Dr. Made. Want to ask, during this pandemic, how about the number of asthma exacerbation cases in your place? Tend to decrease or increase? Can the use of ICS in asthma have beneficial effect during pandemic, either by prevent SARS-CoV-2 infection or prevent hyperinflammation COVID-19 in patient with asthma?
The last question, I didn't hear the last question. Sorry.
Yes.
There were 3 questions. Yes.
Yes.
The first one was regarding the country where I'm living right now in Panama. Yes. If there is a higher number of exacerbation in asthmatic patients, was the first. The second one was regarding if the ICS protect to COVID-19 in that terms. And the third question was regarding, please.
Can the use of ICS in asthma have beneficial effect during pandemic?
Okay, thank you so much. No, truly, I will say that when we know about this pandemic,
yes,
that it became in China in December.
yes.
Obviously, in my country right now, it became in March, okay? My first point was, and is the point that we should have with all our patients, is for any, I will not say only for asthma, for any chronic disease we should try to have the better approach or the better control. Let's say diabetes. Every diabetes patient, this is a chronic disease. We should try to control as more patients we can, also in hypertension, also with COPD, and also with asthma. So every condition, every chronic condition should be well controlled to reduce the hospitalization of those patients, because we need the beds for patients with COVID. So that was the first reason that we were telling to our patients with COPD, asthmatic, hypertension, please, you should be receiving your controller medication. In terms of asthma, ICS, ICS-LABA, and obviously biologics. My feeling was, and I should tell from my side, that some societies only until April or May of this year, they tell us that you can use the ICS or ICS-LABA or even the biologics in that way. But we as physicians, I remember that with my community, I told them we should try to achieve best asthma control as better than even in the past, to have more beds for patients with COVID-19. That first. Second, what we know right now, the patient with asthma, they have the same risk to get COVID-19 that any kind of individual. So we should try to maintain, to use the nasal mask, to have at least 2 meters of social distance in that way, and to wash the hands, to be using the control medication. And obviously, what in the last, let's say 5 months, what we know is that also ICS in that way improve in the airways, the AC in that way. So where the COVID-19 could be, be binding in the airway, could be reduced by ICS. But this kind of patient, as with the COPD patient, they have risk, obviously, to be infected. But obviously, as most of our patients, they were at home because the lockdown, they have less risk to have this kind of disease, But obviously, this was a really important points here. And Panama has only 4 million of people, population. Venezuela, my country, has 34 millions. And here we have, right now, we have near 130,000 cases in Panama of COVID, where the country with number 34, I think, around the world, with only 4 million people. It's a small country with a higher number. Yes. Thanks.
Thank you.
Thanks, Dr. Budhi.
And for Dr. Mulyadi, adakah kriteria-kriteria yang bisa dipakai untuk melihat kontrol asmanya pada pasien dengan cara telemedicine?
Terima kasih. Jadi dalam kaitan telemedicine, tadi sudah kita diskusikan bahwa targetnya pasiennya terkontrol. Pasien terkontrol itu bisa kita peroleh dalam konteks konsep family medicine. Telemedicine tadi itu berdasarkan kuesioner yang tadi sudah kita diskusikan. Kalau maksimalnya 25, di atas 20 itu terkontrol dengan baik. Dan untuk mencapai itu ada 2 hal sebetulnya yang perlu kita perhatikan. Yang pertama, kepatuhan daripada pasien terhadap problem asma. Yang kedua, pemilihan medikamentosa, obat-obatan. Dan di sini jadi penting karena pemilihan itu tidak selalu mudah, dan ada beberapa hal yang harus kita pertimbangkan. Yang pertama tentang pemilihan terkait dengan konsep biofarmaseutik daripada obat tersebut. Dengan kita bisa lihat preparat-preparat yang memiliki berat ukuran partikel yang maksimal yang paling kecil hingga bisa sampai ke ukuran terkecil daripada saluran nafas bawah. Yang kedua, alat yang dipakai untuk itu kan sekarang banyak tersedia beberapa model, sehingga yang paling mudah dipakai oleh pasien dan mudah didapat. Nah, itu merupakan pilihan utama. Semuanya tujuan untuk mencapai asma yang terkontrol dengan baik. Itu dari saya mungkin, Dokter.
Oke, baik, terima kasih Dr. Mulyadi. Lalu kalau untuk pasien dengan telemedicine, kan kita sudah tahu ya, kita sekarang mungkin udah hampir 10 bulan lah ya, atau mungkin 9 bulan dalam keadaan pandemi. Itu apakah bisa kita teruskan selama setiap bulan untuk melakukan telemedicine, atau memang pasien itu diberikan penjadwalan untuk mungkin 3 bulan sekali ngambil obat sekalian kontrol gitu, atau gimana ya, Dok?
Ya, itu pilihan. Idealnya memang setiap bulan pasien itu tetap mendapat obat yang tadi disampaikan oleh Dr. Gur misalnya. Tapi pada kondisi tertentu obat itu bisa dipakai terus selama 3 bulan kalau dalam bentuk ICS tadi itu. Dan sambil nanti kalau ada keluhan kita bisa melakukan telemedicine lagi kan dalam bulan-bulan berikutnya. Jadi obat itu sebetulnya tadi yang disampaikan oleh Dr. Gur itu cukup informatif tentang menurut saya ya tentang asma yang terkontrol itu. Jadi telemedicine bisa kita pakai setiap bulan atau paling tidak setiap bulan atau minimal 3 bulan. Itu pendapat saya, Dr. Budhi, untuk mencapai asma yang terkontrol.
Okay, I will ask to Dr. Gur. Here in Indonesia, we give the drugs, especially inhaler, for 3 months for patient with asthma because we have a pandemic. Yeah. How about in your country?
Okay. No, and when you ask me regarding my country still is Venezuela. I'm living in Panama right now, but my heart is in Venezuela. But let me talk about Panama because obviously I'm here working also. Yes. So in that way, no, every patient, he could be receiving his drug every month, okay? Mm-hmm. But they should be receiving it at home. They were receiving as delivery the drugs at home.
Okay.
For those that they has Social Security. For those that they has Social Security. I will say that in Venezuela was not, because we have a lot of issue right now in Venezuela. That was the reason I leave Venezuela in that way. So, but in Panama, right now, the patient, they were receiving as delivery their drugs in the first, from, let's say, from May to August. And right now they can receive it they can go to the office and receive the drugs. Yes. But that's what you're doing right now in Indonesia. I believe it's really important because if you can give to the patient at least 3 months, and with 3 months, I will say, you should initiate any patient with at least for 3 months of treatment. And after the 3 months, you should understand if that patient you should step down or maintain the treatment that base. The only issue for me will be what will happen if that patient will need a step up. And this question will be for you. I have a patient. He's better as NERD, my patient. But after 4 weeks, that she was receiving fluticasone propionate plus ameter 125 twice daily, my position was to increase the dose because she will be needed. So you can give to your patients 3 more months of treatment, or what will be the approach in that way in Indonesia?
Maybe Dr. Mulyadi. I think every month the doctor will asking about the control status of the patient. Yeah. Okay. After if there is an exacerbation, it's better contact the doctor and then maybe going to the clinic and meet the doctor directly.
Okay. Okay.
Mm-hmm.
Thanks.
Dr. Mulyadi, maybe. Is there comment?
Ya, itu tergantung ya, tergantung kepada, menurut saya sejauh itu terkontrol, mungkin di obat itu bisa dipakai selama 3 bulan berturut-turut, jadi tidak harus, tergantung situasi pasiennya kira-kira. Itu Dr. Budhi.
Yeah, Dr. Mulyadi said that if the patient have a control status within 3 months, they give the government will give the drugs same as previous one. If there is an exacerbation, better go to the doctor or polyclinic.
Okay.
Okay. And the other question for Dr. Gur, how about overuse of SABA? One of factor for using fixed dosing is still using SABA, while with MART therapy, there is no SABA, so it can help prevent SABA overuse.
Really great question. There is a lot of, noise regarding short-acting beta agonists. Let's say,
yeah,
in the studies of Sigma 1, Sigma 2, Fractal study, and START study, any of those studies show to us that in the arm of short-acting beta agonists, they have higher mortality. So with those studies, there was no evidence of mortality during a year. So that's not true regarding that way. What I really understand, as I am the first one in the front line that I tried that my patient will not be using short-acting beta agonists, not regarding the mortality, because the point here, the mortality is not related to the short-acting beta agonists. That's not true. The mortality is related to the uncontrolled. So if the patient is uncontrolled, if the patient is not well controlled, he will need more and more rescue medication. Obviously. How we can reduce the short-acting beta agonists? With control medication. And as I showed to you, and there were no those studies. Maybe you don't know me, but I was also the president of the Society of Venezuela during 4 years, and I'm talking about the same in the last 20 years. We should try to treat our patient in fixed dose, regular dose, and with that, we will reduce the risk of short-acting beta agonists, and in that way of exacerbation. And I will tell you something also in that way. If you review Gina Strategy, the step 5, there is any study they show to you that in the step 5, there is any study that prove that patient can use this mark therapy? It's impossible because those patients will need to use a third controller. So in fixed dose with fluticasone propionate plus salmeterol, less patients use short-acting beta-agonists. And I will tell you something else regarding the asthma control test. And this is not something that is in the Gina strategy. When in the fourth question, when we're asking to the patient regarding the last 4 weeks, you know, in the last week, if you have been using rescue medication, it's not only regarding salbutamol, it's also regarding terbutaline, it's also regarding ipratropium, it's also regarding ipratropium plus phenobarbital. Yeah. And you know what I mentioned also here? ICS for formoterol. I will tell you why. You will tell me, maybe, ICS for formoterol has ICS. So it's not only rescue medication, but I will tell you why I use, when I educate to my patient, I told them, if you need to use the ICS for formoterol as needed, it's because you are not controlled. You are not controlled. So it's the same. Maybe you will have less risk of mortality than using only short-acting beta-agonists. But here the point is control. Control and control. And I am very afraid, I will say, I'm very afraid right now. I will tell you why. I'm not young. I have 57 years old. And during my last 25 years, we know that for our asthma patient and COPD patient, always the community has been talking about the inhalers, the risk of mortality using any kind of device. Also regarding the ICS device, you know, all the side effects of the ICS using ICS. That's the reason that we're talking so bad about the inhalers that sometimes patients, they avoid to use inhalers and they try to use pills for their asthma or any kind. So we should give the truth to our patients in that way. So try to achieve well asthma control, and patient will use less short-acting beta-agonists. And if a patient will be using ICS for formoterol as needed, it means that the patient is not well controlled. It's the same. He will have less risk of mortality, but he's not well controlled.
Okay. Okay, so the target is well control, never
well control,
never exacerbation, right?
I will say never exacerbation, less use of rescue medication,
yes.
Not wake up regarding symptoms during the night.
Yes.
Try to have physical activity. And I was reviewing a paper for Indonesia, also a study regarding physical activity and asthma control. In that way, I review a lot of papers regarding Indonesia, regarding asthma for this talk.
Okay, thank you. Another question is, how is your experience using omalizumab, anti-IgE, for moderate and severe allergic asthma, especially during this pandemic?
Okay, never to moderate asthmatic patient. Never to moderate asthmatic patient. I will say that right now, I don't have any patient in Panama with omalizumab. I will have to be honest in that way. I will tell you that at least in my hospital in Venezuela, we had 49 patients with omalizumab. We were using omalizumab for during the last 15 years, okay, 14 years in that way. In my hospital, we have It's the most important hospital in Venezuela, in Caracas. It's a good drug. The point here was that at the beginning, when doctors were using omalizumab, they were using the drug for every patient for every severe asthmatic patient. And that is really bad. You should be looking for patients that you should phenotype those kind of patients. Those patients should be at least with 2 controllers with severe eosinophilic asthma, and they should be allergic patients to receive this kind of drug. And we have omalizumab, and we have other kind of drugs in that way. So we can reduce the use of oral corticosteroids. We also can reduce the exacerbation and to improve the quality of life in that way. We have other biologics right now that I'm using because sometimes I'm going to Spain and still have a good relation with my hospital in Spain, in Barcelona. And I have more, let's say right now, I have more exposure to other kind of biologics for that one. But obviously I had good experience with omalizumab. If you phenotype the patient well, it's a good drug. And obviously, in that way, if the patient is in step 5, sometimes as the patient is receiving those kind of drugs, subcutaneous, patient, they think that they should avoid the use or they improve their asthma, they could avoid the use of ICS or ICS-LABA. That's not true. They should be maintaining their ICS or ICS-LABA, the 2 controllers in that way. They should not avoid or eliminate their controllers, because sometimes the patients do that. But obviously we can talk about that in other way. And using fixed dose for severe asthmatic patient, not using variable dose, because that is the reason that they will maintain inflammation, error remodeling in that way.
Okay, thank you. And the last question, maybe for both of the speaker. First for Dr. Mulyadi. Seringkali pasien asma berbarengan dengan gangguan cemas. Ya, terkadang dia tumpang tindih antara asma dan cemasnya. Apalagi dalam kondisi pandemi saat ini. Bagaimana menyikapi hal tersebut?
Ya, terima kasih. Itu seperti mana telur mana ayam ya.
Ya.
Ya, cemas dan asma. Asmanya menyebabkan cemas, cemasnya menyebabkan asma.
Ya.
Jadi dalam konteks inilah peran daripada telemedicine sangat membantu. Dan di mana pada kondisi-kondisi tertentu di daerah-daerah di mana mungkin dokter-dokter baru belum hadir, maka peran telemedicine akan mengambil tempat yang sangat strategis. Dan pemakaian obat seperti tadi sudah disampaikan bisa terus selama 3 bulan, sambil kemudian problem domestik yang menyebabkan kecemasan itu juga bisa. Jadi konsepnya kembali kepada telemedicine yang kita diskusikan tadi. Demikian Dr. Budhi.
Baik. Terima kasih, Dr. The question is, Dr. Gur, patient with asthma, they have also the anxiety.
Yes,
yeah.
Anxiety, yes.
Anxiety. So, how to distinguish between this is asthma, this is because of the anxiety, and then how to treat patient with like this?
Really great question. This is obviously all the questions that you did today are really good. This one, let's say, is part of my first slide. If you remember, state of the art, that was part of the comorbidity, because patients sometimes they have a misperception, or overperception. They could have anxiety, and we cannot know if they're not well controlled, because their anxiety or the anxiety is the cause of the uncontrolled. So in that case, obviously, what we should be doing here, first of all, to see if that patient has asthma or not. Let's say, yes, they have their asthma, they're receiving the controller. We should be using the asthma control test to see if, let's say, how is the point by point, question by question. I should be using the lung function or the peak expiratory flow to see how is the relation between her symptoms or their symptoms with the FEV1. We know that there is no good relation, but at least is to know. And obviously, we should try to manage this kind of patient with a psychology or a psychiatric in that way. We cannot manage this kind of patients alone. And if I will be talking not only regarding asthma, also regarding COPD, because I have a lot of patients also with COPD, one of the risks of mortality in COPD is higher mortality in those patients that they are anxiety and they have depression. So, and there is a very nice paper done by Miguel Divo from Harvard University in Boston that in respiratory disease, those patients that they have anxiety, they have higher risk as a comorbidity, they have higher risk of mortality. So here we cannot manage the patient alone only with drugs. We should, obviously, we should try to manage that with also in your country, I don't know if maybe with a psychology or a psychiatric in that way to understand how is their level of anxiety and the level of depression in that way. That is really important because also for those patients that they're overestimate or have a over perception of their symptoms, part of the anxiety, they will be using more and more rescue medication or more and more ICS for motor, and they don't need it, you know, because they're hyperventilation in that way. So we should try to not to work alone for those kind of patients. I will say that they're the patients that they are more difficult to treat, those patients that they have psychiatric condition, because obesity, sleep apnea syndrome, cardiovascular disease, it's easier to manage than those patients that they have any kind of psychiatric condition. Mm-hmm.
Yeah, you mentioned that maybe we can asking the patient spirometry. Yeah. But in a pandemic area during the COVID, we refuse the.
We cannot. Yes.
Aerosol.
True.
Is it enough to from the saturation?
The oximetry. No, the oximetry. You know, if the patient has anxiety or not, the oximetry will not fail, because obviously, you can make a lot of exercise, and the oxygen saturation will not fail. Okay, the oxygen saturation will fail with other kind of condition. Will not if you're healthy, you don't have any risk to fail in the oxygen saturation. As you mentioned, obviously, during this pandemic, it was impossible to do a spirometry, and one of the reasons is to reduce the possibility to spread the disease. Also, not only spirometry, also to avoid nebulization.
Yes.
Because nebulization at home, because we know that sometimes patients use nebulization at home as for rescue medication, and also there are someone that are using as controller that is a mistake, because when we compare nebulization and MDI plus a spacer for rescue medication, it's better to use the reliever with a spacer than to use nebulization. You need less time, you don't need electricity, you don't need the machine. And regarding the spirometry right now, I will tell you, I mentioned during the ERS, I present one case, my first case that was with COVID-19, with asthma. She has asthma with COVID, and what we did is she has a peak expiratory flow at home. So she was doing the peak expiratory flow at home. So you can change, and it's obviously the peak expiratory flow is cheaper, and every patient can have the peak expiratory flow. And we know that this pandemic we should live with this pandemic maybe for 1 more year at least, or let's say we don't know how many years we will be living with this, with the COVID-19 in that way. That changed our lives.
Yes.
Change our lives.
And the last question for me, now Gina 2020, they launched the ICS Sabah as a
formoter. ICS formoter.
Yes.
Mm-hmm.
Why?
No, I will say you why. Obviously, this is not a new drug. This is the same drug that we have in the last 15 years.
Yes.
Obviously, I will say to include that drug as part of the strategy, you need studies. And they had the studies, okay? They have the study that show regarding ICS formoterol that it's, let's say, better than to use short-acting beta agonists to reduce exacerbation.
Mm-hmm.
So the point here is, Gina cannot, avoid those studies. What they're giving to us is part of the strategy. But if you read the strategy, if you not only see the chart, you should read the papers, you will see. If you will want a medication for your patient only as a rescue medication, I will tell you that ICS formoterol, it's a good drug. Why not? I will tell you something else. I don't know in Indonesia, but in Venezuela, we had in the past, and also in Panama and all Latin America, beclometasone plus salbutamol.
Mm-hmm.
I don't know if you had that in Indonesia, but in Venezuela, in Latin America, we had a lot of beclometasone plus salbutamol. So short-acting beta agonists plus ICS in the same device before the ICS LABA. What happened? The patients were receiving the ICS beclometasone plus salbutamol as rescue medication. What happened with those patients? They were uncontrolled with risk of mortality. We should be, for those patients that they are receiving today, that is part of the strategy, but you should know, with both the strategy, if the patient is receiving ICS or ICS formoterol, there is no difference regarding the risk of exacerbation. But in terms, if you're going to achieve asthma control, ICS, it's better plus short-acting beta agonists. So I will ask you, if I have two different drugs, they have the same efficacy for one objective, but one of them has a better improvement, let's say, of other point, what you will be using? That has two objectives, or that has only one of them? I will be using this one. Yes. And so
great.
It's only a strategy. You can use it, but your patient will they will not achieve asthma control. They will have inflammation. They will have more hyperactivity. They will have more remodeling. If they will have more remodeling in the future, they will be more severe asthmatic patients, and yes, they will be receiving biologics for their severe asthma. So I will achieve ICS or ICS LABA fixed dose better than any other strategy.
Okay, I think this is the end of this webinar. So I will read the take-home message from Dr. Mulyadi. Asthma is this This is cause of chronic airway inflammation that needs long-term steroid inhalation treatment. Telemedicine is a new concept that can be used to help patients with chronic illness like asthma to stay under control. And then from Dr. Gur, the long-term use of controller medication help to control asthma and reduce the risk exacerbation. There is no scientific proof that shows the use of ICS-LABA related to symptom is better compared to the conventional therapy monitored by doctor. Achieving control state effectively and efficiently will contribute to the patient compliance to the treatment and build a solid doctor-patient relationship in long-term management of asthma. Is there any addition from this take-home message, Dr. Gur?
No, from my side, no. It was a pleasure to be with you in Indonesia, with you, Professor Budhi, with you, Professor Rajan, and with the PI society in that way. So my pleasure to be with all of you, and I hope that you and your family will be well.
Thank you. Thank you for your wish. Okay, Dr. Mulyadi, terima kasih. And then Dr. Gur, thank you very much. I will close this webinar. Also, thank you for all of participants today. Bye-bye.